All right, so thanks everyone for joining us again today for our third implementation sharing webinar as part of this AHRQ Fall Prevention Program. Today, I'm happy to say that we have some special guests who are going to be talking a little bit about post-fall huddles with us today, one of which is our expert, Julia Neily, and also one of her colleagues, Vanessa Coronel from VA Boston, will also be talking about that. But before we get started, we're going to do just a little bit of housekeeping and a couple of updates from our team. That will take no more than about 2 minutes. And then we're going to have a brief update from Mayo Clinic Health System, who's going to talk a little bit more about what they're doing right now on reinforcing their intentional rounding. And this is part of their implementation activity. So we're going to hear a little bit about that from them, and we'll have a quick question and answer related to that. Then we'll go into our post-fall huddle discussion, and then we'll leave off with a period of discussion for the presenters and some any questions that folks have. And that's going to actually be led by McDonough with Ashley Frederick, sort of leading off the discussion. So first, let me just, some of the housekeeping stuff. I wanted to just remind everybody that when we do get to the discussion section, that if you have a question or you have a comment, please raise your hand. And I see that somebody already has their hand raised. But when we get to the discussion section, please use the hand feature. You'll see the little hand icon on the right-hand panel. And then you can also type in your questions. If you don't want to ask it out loud, if you'd rather type in your questions, you can certainly use the chat panel to do that. Just make sure that you select using the little drop-down box to send to all panelists. The other thing I wanted to remind everyone about is please use your mute feature. You have 2 ways to mute. One way is to just use the mute feature on your phone. Alternatively, you can use the mute feature that is part of the WebEx system. If you've logged in, you'll see a little microphone next to your name. You won't see it anywhere else but next to your name, and you can use that to mute yourself. Just make sure that when you are ready to ask a question that you unmute yourself. All right, so just a couple of updates. Wanted to let everybody know that we heard you loud and clear following our last webinar when we asked you about how you wanted to connect with the hospital, the other hospitals outside of these Learning Network webinars. And the vast majority of individuals would prefer to have a contact list. We had asked about the possibility of using a LinkedIn group, but we didn't get the kind of interest that we would need to really launch that. So we decided against using a LinkedIn group and instead prepared a comprehensive contact list that has the information on how to contact any of the hospitals that are participating in this initiative. You will also see on that contact list that we have provided information about each of the hospitals' specific implementation focus areas. So that gives you a sense of, what they're working on. And then also any other resources that they are at least aware of that they'd be happy to share with you. And this is a list that can be updated, so if you find that there are some additional things you'd like to add next to your hospital's name, just let us know and we can certainly update this list. It will be available in the Dropbox folder so that you are able to get access to it if you misplace it. The one last thing I wanted to mention is that we in our poll following this webinar, we have a question about your availability in December. We know that December is it's a pretty crazy month with holidays, so we want to just make sure if you're going to be available at the planned time for our December session. So if you could just make sure you answer the poll, that will help us with our planning for how we want to handle the December webinar. So with that, what I'd like to do is we're going to, as I said, the first discussion topic area for today is just to have a brief update from Mayo Clinic Health System, Franciscan Healthcare, who's going to provide a little bit of an update on what they are doing right now around intentional rounding, reinforcing their intentional rounding. So, Kristine, if you would like to take the floor, we would love to have you share what you guys are doing, and then we'll have a brief period for some questions if anybody has any questions.
Sure, thank you. Thank you for inviting me to speak. So the unit that is our pilot unit for AHRQ is a 30-bed medical unit that primarily takes quite a diverse patient population. We have detox patients, elderly patients, failure to thrive, the Chapter 51, plus cardiac oncology and neurology. So we're quite the box of chocolates. We have one of the highest fall rates in the organization because of those impulsive patients and other comorbidities that come along with their reason for admission. So given the amount of change that we are experiencing as an organization, we really tried to encompass many interventions that would cover a multitude of topics, such as intentional rounding, reducing falls, patient experience, and all of that. So we've decided to focus on really trying to hardwire intentional rounding. I'll start with that one. That is an area that we continue to struggle with just because of our daily churn. Our patients come and go from diagnostics and therapies and whatnot anywhere from 4 to 6 times a day. So when you're managing that churn, to have someone dedicated to go in proactively is a constant struggle. So we have taken that and kind of have just stepped away from being proactive to being mindful to really focus on asking about the 4 Ps with every encounter that you experience with that patient. We have some staff that are more stellar than others, but it continues to be an effort that we continue to hardwire on that. And we have actually just started documenting this in our EHR. We had one of the barriers was having what we call our patient care techs not having the same ability to document as our nurses, and we just had that received within the last week or two and are collecting data now on that success. When it does work well, I know it does put the patients at ease, and it does help them develop more of a trusting relationship with our staff. I think it's still a little awkward for our staff to be asking those questions repetitively throughout the day. So that's where we get into that inconsistency. And the other barrier that we've learned with intentional rounding is that scripting works, role-playing or structured rehearsal works, because it's very easy to push something out but not really understand how it should look, is a learning as well that we're working through. The other couple things that we are working on and have implemented, one is that we have implemented not only our nurse-to-nurse bedside shift report, but also our PCTs from days to PMs has also taken on that format where they go bedside to bedside, doing their introduction, making sure that bed alarms are engaged or chair alarms are engaged, the patient has everything within their reach, again, incorporating those 4 Ps into that process. I wish I could say that that has led to success because even just this month we have had 4 falls, 2 of which are preventable. And when I talk about preventable, that there's 1 or more things not in place per our standard of care. No one was injured, thankfully enough, but to know that 2 could have been prevented speaks loudly. So we continue to work through our frustration and all of that to try to reduce our fall rates, but it's a very frustrating process.
Okay. All right. So do we have any specific questions from the group? Anybody else who's sort of, you know, working on this in their activities, or any advice to suggest? No? So what is your timeline, just out of curiosity, for sort of implementing this change, you know, the changes that you're working on?
We continue to address it daily, ongoing. As far as a structured timeline to hope to see success, I think one of the barriers in that is that we don't have a true benchmark for a unit. When you compare patient days, you know, your fall rate per 1,000 patient days, the benchmark is at an organization, not at a unit level. So it's really hard to determine an exact measure using a fall rate when the goal has been set organizationally. One of the things that I've started to look into is there a fall rate for a unit of like size and populations. So as far as the timeline goes, you know, that is kind of fluid. The more that we learn and discover and realize what data do we not have, we continue to work through those barriers. And once we have all of the information that we need at our fingertips, then we'll be able to set a concrete goal, if you will, using the PDSA language
right,
and move forward.
Okay. Well, it sounds like you guys have a lot going on. Does anybody else have any questions that they want to ask at this point in time, or comments? Well, thank you for sharing that with us. I guess in the interest of time, I'm going to move us on to the topic that we have next, which is on the Post-Fall Huddle. But if any questions do arise, please feel free to ask those later on when we get to the open discussion session. So today we have, as I mentioned, we've got Julia Neily, who is one of our falls experts for this project, and she has agreed to talk to our hospitals about post-fall huddles and how to use those to reduce preventable falls and fall-related injuries. So Julia, I'm going to pass it over to you.
Okay, great. Thanks, Michelle, and hi, everyone. Happy to be sharing with you this afternoon. So what I'd like to talk to you about is the post-fall huddles, and really thinking about this in terms of maybe an after-action review. So this is just a little about myself. I've worked for the VA National Center for Patient Safety since 1984, and I've been a staff nurse, a nurse manager, and had other various roles for the last 10 to 15 years, probably about 15 years now. I've been working for the National Center for Patient Safety, and I've had the privilege of working with many teams throughout the nation in the VA who have been working to reduce falls and fall-related injuries. Let's see here. Okay, so what I'd like to do is talk about not only how to implement post-fall huddles, but how to use the data that would result from the post-fall huddles to ultimately improve your program and reduce falls and fall-related injuries. So the ideal way to do this is within 15 minutes of the fall, as soon as possible while it's fresh in everyone else's mind, to really look at what was different this time, that let's say the patient was getting up to go to the bathroom or trying to, you know, reach for something or whatever may have happened. What was different this time that the patient fell, whereas in previous attempts to do something like that, they have not fallen? when did it happen, how, and really trying to ask why 5 times. Sometimes we think that the reason for the fall is pretty obvious, but it's great to dig a little deeper to really get to the root cause of that. And it's really all about looking to see what could we do to possibly prevent future falls of a similar nature. This is one of the key interventions that we recommend to sites if they're trying to reduce repeat falls. So that's the first part of the safety huddle. If you want some more backup information or you want to practice with this or have some case studies, you can go to the VA National Center for Patient Safety Falls Toolkit. And this link right here will bring you to an after-action post-fall huddle tool, some case studies, a typology tree, and that will help you with your determining preventability of falls. So what are the essential components and how does this really work? Some teams have used an overhead page. Others may use a different way to get the team members there. And again, the idea is to have at least more than one person because on my own, I may not see something that you or other colleagues might see. For example, after a fall, we reviewed the patient's room to look at, what was happening. And from a nursing perspective, I was thinking about things like transferability, strength, medications. But we had an environmental services person with us, and right away he spotted that there were these long cords that were in the way. So everybody has a different eye and a different focus, and a physical therapist is going to see something different yet again than what I would see. So different disciplines are going to bring a different eye to the event. And also, ideally, you'd want the patient involved and asking them what they thought was different. And that's really, as I said, trying to discover the root cause and what we can do to prevent future falls of a similar nature. So this is a guiding question that can be asked of the patient. And again, this will be done in a way that we really want to find out what we can do to support you to prevent future falls of a similar nature rather than any sense of blame to the patient or to any of the staff. So the announcement can be made, you conduct an analysis, and then you can also determine the type of fall. It's very encouraged to hear the first speaker talk about the 4 falls that had occurred and that 2 of them were not preventable. And that's really what we're encouraging people to do because sometimes you can do everything within your power to prevent that fall, and for a variety of reasons it might still happen. So the post-fall huddle, excuse me, is a chance for people to, excuse me, as a group, try to determine that preventability. And again, the purpose, excuse me, is to prevent future falls. Sorry, I have a little cough there. Now, many people use a form to, I have to get a glass of water. Hang on, just one. Okay, sorry about that. Many people use a form to document what they learned in the post-fall huddle. And the purpose of that is to look for tracking and trending, and also to update the plan of care. So here is the decision tree, and this is available on the National Center for Patient Safety Falls website. And as you can see, an unanticipated physiological fall is not going to be preventable. So we really encourage people to separate out by type of fall and to remember that not all falls are preventable. Some falls that are accidental or anticipated physiological may not be preventable either. You may have done everything you could to have prevented that fall. So even those types of falls have their non-preventable types or aspects. So determining the preventability, again, we encourage people to do this as a group with groupthink, because I've seen it go both ways, that sometimes people are very quick to say, well, that was definitely preventable, and then I've seen it go the other way, that none of the falls were preventable. So it's really good to have more than one person contributing to that decision and have a group consensus on that. And as we heard earlier, wisely people said, could the care provider have anticipated this event with the information available at the time? And that's another key aspect. Sometimes after the fall, we learn new things that we didn't know before the fall. And if you're looking for guidance in the literature about preventability or not preventability, we have a source there listed but from Levinson. And again, nobody knows, we can't turn back the time, but nobody knows for sure if something was. So we can, think of it as likely preventable or likely unpreventable. So what are the outcomes of a post-fall huddle? We are able to look at root causes. We're able to look at the type of fall, and then the goal with that is to identify ways to prevent reoccurrence. So, for example, one site was looking at their falls, and they found that a lot of there was a trend with the falls focusing on toileting, trying to get to the toilet, trying to come back. So then you can look at, excuse me, what are the trends, what are the actions we're going to take related to preventing toileting-related falls. And then you can also do it in an individual way and involve the patient and the family in that. Excuse me. So then what are the formative measures? One of the things that you'd want to look at is also who attends the post-fall huddles, and then do we change the plan of care? So again, we want to look at, certainly, do falls and fall-related injuries go down? But sometimes we might be wanting to implement post-fall huddles, but we're not actually doing that. So you could take the number of falls that you've had and then look at how many of those had a post-fall huddle. You can do that simply by using observation. You could also look at how soon after the fall was the huddle occurring. We're working with a group of facilities that are care for veterans, and some of them are doing, which is great, a weekly review of falls. What we're talking about is something that happens very soon after, an after-action review, a post-fall huddle that happens, as we said, as soon as possible after the fall. Not, certainly a week later, looking at your trends and reviewing them is great, but we really are emphasizing here, what can we do for this individual patient right away? And then if we do change the plan of care, how quickly did we do that? Sometimes with repeat fallers, we may have a situation where the patient falls, but the plan of care isn't changed quickly enough, so then the patient falls again for the same root cause. And that's definitely not something that we want to have happen. So then the outcome measures we want to look at, are we reducing falls? So sometimes repeat falls will be the first fall, and then the second fall is for a completely different root cause that you may not have been able to predict. So you definitely want to look at, are we preventing repeat falls that are the same types of the same root cause, like say getting up to go to the bathroom or reaching for something that was not available to them. And we may also ideally want to reduce costs associated with falls and fall-related injuries. But the very first and primary issue is we want patients to be better off as a result of reducing falls and fall-related injuries. So what are some trends? We mentioned the toileting trends as an example. Could also be trends related to environmental causes like bumps in the floor or something like that. Shower stalls, sometimes people have had problems with the way the water flows in a shower stall, or the floor is slippery, things like that. One site was sharing with us, they noticed that, this is a long-term care facility, that certain days of the week had more falls, and then when they looked into that further, they found that they had a barber shop there, and on those days there was fewer people were falling because they were engaged in an activity, so they added more recreational activities to decrease the falls. And then this other bullet here, lunch and other breaks or shift handoff. Many teams have shared how they can sometimes see problems when there's not good coverage during lunch or breaks or shift handoff. So how do you measure, are we doing post-fall huddles, and are they making a difference? Well, we really encourage people to keep it simple. Sometimes people get bogged down by documentation related to the post-fall huddle. Our first action is to take care of the patient and care at the bedside, and then to look at how can documentation help us to improve that care or track the care that we're providing. So again, as I mentioned earlier, observation is certainly an option for you to do. And to keep it as simple as possible, paper and pencil, tally, or looking at the data over time. Again, examples of process measures. What are the percentage of patients at risk for falls and fall-related injuries with the interventions in place? That's something you're probably already looking at, and maybe even you're looking at that when you do your intentional rounding. You could also look at patients with completed intentional rounding, and as I mentioned earlier, the most important thing related to post-fall huddles that I would say in terms of process measures is of the falls that we've had occur, how many have had a post-fall huddle, and then after that, how soon did that occur? So the outcome measures, always I like to think of outcome measures as how do we know if the patient's better off? Are major injury rates related to falls or injury rates in general related to falls going down? Are the fall rates going down? And a balancing measure, of course, we don't want to do this at the cost of a patient's independence or mobility, so it's a delicate balancing act. So that's more of the overall, structure and process and ways to approach post-fall huddles. But I'm really excited now for you to hear from the Boston VA Medical Center, where they have a great program for implementing post-fall huddles. And Vanessa Coronel will be leading this talk along with Susan Shannon, and Amy Hansen will be speaking as well. Vanessa has been involved in the Falls Virtual Breakthrough Series in the VA for a long time and presented nationally as well at conferences about her program. So we're really excited to hear from Vanessa and her team, and I will now turn it over to her, and I'll advance the slides for you, Vanessa. Just give me a holler when you want me to go to the next one.
Okay, thank you so much, Julia, for that lovely introduction. Very generous of you. Hello, everyone, and thank you for having VA Boston today. My name is Vanessa. I'm the Patient Safety Nurse and Falls Prevention Coordinator. And let me just give you a brief overview of VA Boston. We're a primary tertiary care referral center for 5 New England states with 3 main medical centers and 5 outpatient clinics. VA Boston provided care last year alone to some 62,000 veterans, and close to 700,000 veterans visited our primary and specialty clinics across all disciplines. We are also a teaching hospital for Harvard Medical School and at least 5 nursing schools in the greater Boston area. So as you could see here on the slide from left to right, our VA Boston's the 3 medical center. To the left, Brockton mainly focuses on the long-term care setting. Jamaica Plain in the middle is for outpatient, and West Rocks is for acute care. Today, I am joined by outpatient Falls champion Nurse Sue Shannon and Nurse Amy Zamiara, Falls champion for long-term care. Next slide, please. As Julia has mentioned, to prevent falls, we need to huddle. So how do we perform the huddle the VA Boston way? This is actually a poster or a screensaver that you see here right now. It features actual VA Boston nurses, PT, pharmacists, and it encapsulates the huddle in 3 basic steps. So step number 1, again, as Julia has mentioned, find out how did the fall happen. If possible, involve the patient, get his viewpoint. Step number 2, which we consider to be the most important step is determine the root cause of the fall. Why did the patient fall? For your strategies to be effective, you need to target the root causes of the fall. And step number 3 is how can we prevent the fall from happening again? Implement interventions based on the root cause. If your patient is more likely to occur, then our strategy now is to reduce the severity of the injury. So for example, in Brockton, we use a floor mat and actually the lowest bed possible because studies have shown that this reduces hip fractures and subdural hematoma. Next slide, please. What you see here is a screenshot of the post-fall huddle form, and actually we made it electronic, and it's embedded in our fall incident reporting system. At the VA Boston, we place a patient safety icon in every laptop and workstation. So we're looking at about close to 6,000 workstations. Anyone could access the patient safety icon. Making the huddle form electronic cuts down on the number of steps that clinicians have to take in order to do the huddle, saving the frontline staff time. As you could see here on the upper section, the clinician is required to check the activity before the fall and for any contributing factors. Then we categorize the fall if it's accidental, anticipated physiological, or unanticipated physiological. And to make things more convenient for the frontline staff, a checkbox is actually included for huddle recommendations or strategies, be it do we need to review medications for this veteran, we need to use non-slip stocks, or do we need a PT consort or a wheelchair consult in terms of wheelchair belt. From a patient safety perspective now, and looking at the bigger picture, there are 2 main reasons why we use the post-huddle checklist. If you see here on your screen, it's a checklist. First, it serves as a guide to what clinicians should be looking at when they're doing the huddle. In the front line, we know that nurses are very busy and can only remember so much. The checklist that we have here serves as a cue and forces the team leader to ask the team these pertinent questions. Second function or reason is the checklist reduces the variation of how a huddle is performed. So be it a new nurse or a nurse with 20 years experience, or be it a physician or a physical therapist filling out the form, they tend to look at the same factors as they see this post-huddle form. So to summarize, making the post-fall huddle checklist electronic is efficient because it saves the frontline time. And it also serves as a guide to ask the right questions after a fall, thereby reducing variation. And next slide, please. So why do we huddle? Just to reinforce what Julia mentioned, there are 4 reasons. First, to determine the root cause of the fall. Why did it happen? Very important. Second, the huddle checklist serves as a guide of what to look for in a fall. And third, this is an opportunity to engage the patient and the family, and it also builds teamwork. You know, like falls prevention could be nursing driven, but you know what? It's everybody's business, from nurses to PT to physician to the family of the patient and the patient, him or herself. And fourth, based on the root causes of the fall, as Julie has mentioned, we look at the trends every year from patient safety, and we develop far more effective strategies since we address the real reasons behind the fall. Looking at facility-wide changes, post-fall huddle recommendations are reviewed every year by patient safety, and recommendations have led to facility-wide changes in VA Boston, and which we will discuss on the next slide. Amy and Sue will share this with you. This is the slide. Amy?
Okay. Hi, this is Amy from the Brockton Division. In the long-term care setting from our huddles, a lot of our anticipated psychological and repeat fallers are due to the number of medications that they take. They could be hypotensive, hypoglycemic, and could feel just dizzy considering the side effects of the medication. A post-fall medication review was implemented in 2013 by patient safety and found that polypharmacy was actually the root cause of some of these falls. The 3 ladies that you see in the pictures are the pharmacists that are reviewing the medication, and they are alerted of the fall through the patient safety incident report that was previously shown. They will then follow up with the nurse, they'll call the unit, and ask detailed information and questions about the fall. They also co-sign the providers on the notes that they write, and the provider will then take the action and reduce the dosage or discontinue the medication altogether if it's no longer needed. So Sue, you can now share your outpatient experience.
Hi, this is Sue Shannon. I'm the champion at the JP campus of Boston. For us, it was a little harder to get started where we have all outpatients here. So there's no true prevention because you can't assess the patient for risk because we see a couple of thousand patients in a week and we don't know who's coming. But we did notice there was a trend in our falls outside the building that we had areas which needed physical repair. There's the first, in the corner of that slide at the bottom, there's the pothole in the parking lot that had come from a leak in the ceiling or something. That Vanessa, myself, engineering, EMS, we now get together after falls, check the area for any physical hazard and to see if we can repair it immediately or if maybe we can address it in the future. And as you see in that middle part of that bottom, that they patched over the pothole quicker than in Boston. And then the third picture there is actually a bottom of a stairwell in the patient garage. We'd had a couple of patient falls in that area, and we as a group decided that when they come out of that stairwell, the light shifts, it gets brighter as they come outside, and the contrast between the curb and the cement, the tar there for the driveway itself was hard to distinguish. So just as a simple fix, we painted it a bright yellow so that they could see the contrast and see that there was actually a step there. We actually had a patient fall with a major injury there and haven't had a fall there since. We also had a huge issue with ice in the winter and patches of ice here and there with patients would slip and fall between vehicles. This past winter, we actually, working with engineering, the police, EMS, who all are responsible for removing the snow, managed not to have any falls this winter related to ice and snow, which after this winter I thought was a major feat. And I think, like I said, it was a little difficult for us to start, but then we figured out who the players were that needed to be part of the post-huddle, that we all got together and we would check the sites and see what could be done about them. We also, if you could show the next slide, we also came up with a courtesy van because one of the other issues was patients who would get short of breath walking down the stairwells, or the ice, too, was also an issue, where now if they call, the shuttle goes around the campuses. We started it at JP, but have added it to the other two sites also, where all day long there's a shuttle that they can get from their car to the front door and back again at the end after their visit. We at JP have over 600 weekly courtesy drop-offs, and they're also utilized at the other two campuses. And this has impacted slip and falls and shortness of breath and falls. Sorry, back to you, Amy.
Okay. As you can see that we use the 5 Ps in the VA system, and hourly rounding has reduced our falls by about 10%. And based on our huddle reports generated by the patient safety report, there is a trend between 25 and 35% of all falls were related to toiling. So as we do our rounds, we make sure that we pay close attention to those toileting needs. We check for incontinence, urinal assistance, if the call light's within reach, if they need assistance transferring, and we do this at that time. So that's pretty much it. So back to you now, Vanessa, for your final slide.
So thank you, Sue and Amy. So I believe the audience would really ask this question. So with what you guys are doing, is the huddle really effective in reducing falls? The chart here would tell you the answer. From fiscal year 2005 to 2013, falls in VA Boston used to be the most common reported adverse event. And now it's not anymore. So it's a great thing. So it's always a work in progress. And if you guys need any of our screensavers featuring our own nurses and falls champions, we're very happy to share them with you. And again, on behalf of Nurse Shannon and Nurse Hansen, this is Nurse Coronel. Thank you for having VA Boston share our strategy in using the Post-Fall Huddle. Back to you, Julia. Thank you.
Great, thank you so much. I really appreciate you sharing that. And I think, Michelle, now do we open for questions?
Yes, please. That was really great. So if you could advance to the next slide.
There we go.
All right, great. And I believe that we have some questions. Ashley Frederick is going to sort of open the questions for us. And then please, for anybody else who's on the line who has a question that wants to ask Vanessa, Julia, or even Mayo about any of the activities that we've heard about today, please, raise your hand, use this opportunity to hear from them. So, Ashley, do you have some questions that you would like to lead the discussion with?
I do. Thank you very much. And I just wanted to say thank you to all of the presenters. You guys had a lot of great information to share. The first few set of questions that I have are really geared towards Julia. You mentioned, I think on slide 15, some of the steps to the post-fall huddle. You'd mentioned that it's supposed to convene within 15 minutes with the patient. How do you really make that a priority, especially when there are, lots of other priorities that are occurring at the same time, other urgent patient needs? In other words, how do you really get everyone there that you want to include?
Great question, and what teams have shared from in the breakthrough series, the way they've approached it is to maybe do the overhead page, and also, the 15 minutes is a guideline. It's obviously if there's like a code going on the floor at the time or something like that, you're going to have to balance out what is the most urgent need at this time. But the idea is to do it as soon as is possible and as safely possible so that it's fresh in people's minds. And likely people, are saying to themselves and maybe to each other, wow, how did that happen? And there's some sort of discussion going on at that point. So, if there's any way that it can be incorporated to what's already being done. I mean, likely the physician's going to be called to come down and evaluate the patient, those kinds of things. So really trying to balance out the other competing commitments, which I know definitely exist, and at the same time trying to work it into already existing processes.
Thank you very much. And also on slide 18, you had talked about steps to the post-fall huddle, and I believe step 6 stated modifying the fall prevention plan of care to include interventions to prevent repeat falls. Is this something that you always have to do, make sure that the plan of care is modified? We don't want to necessarily just create busy work. So if the fall was not preventable, do you have to make changes to that plan of care?
I mean, from my perspective, I always encourage people to save their time and energy for care at the bedside. If there's not something that needs to be documented, then spend the time with the patient instead. I mean, that's how I look at things. And you're right, if you don't want busy work. So if the plan of care isn't going to be changed, then I would spend the time with the patient instead.
Thank you for that clarification. On the same slide, steps 7 and 8, you mentioned communicating the updated plan of care to the patient or the resident and completing the EMR post-fall note. How do you ensure that everyone going forward knows about the fall and any of the changes that have been made because of the fall? Sometimes it's easy to pass along, to that next shift, but ensuring all that information is continued to be passed on from shift to shift.
Yeah, that great question. I think it's the question to be asking. I definitely heard stories where people, days tells evenings, but does evenings tell nights, and they had no idea that the patient fell or what the change in the plan of care is. So definitely that's an important piece of it. I think, one of the things that Vanessa brought up that I thought was a really key aspect of, patient safety in all areas is standardizing our processes and using cognitive aids to help us to provide care in the same way each time to help us not forget steps. So if people have handoff communication tools and falls and changes to plan of care in falls are on that communication tool, that can serve as a memory jogger. So what I'm suggesting is standardizing the processes to include addressing fall risks and any other safety risks. So that's really what we promote with patient safety in general. It's tough. I agree with you. It's not easy, and that's why we try to use cognitive aids or standardized processes whenever possible.
Thank you. I just have a few more questions, and I don't know if Vanessa or whoever wanted to jump in on this, but I just had a question about reporting information from the huddle back to the staff. What information do you use, and then how do you really make it meaningful and report that back to the staff?
Amy, you want to tackle that question?
Sure. It's initially passed off in report after the huddle, so we have the end of shift report. And then from report, it will go into our rounding, which we do Monday, Wednesday, and Friday. And then from rounding, it will ultimately go to our, we call ITP meetings, our interdisciplinary meetings, where it's discussed with the entire team, with PT, OT, all the providers, the nurses, everybody's there. Just to cover all of our bases. So we do talk about it multiple times throughout the day and the week. And it's also care planned.
Thank you.
And I also see there's a question that came in through the chat. And I'll address this to Vanessa or to Julia. Are there key differences in the post-fall huddle for the inpatient setting versus the outpatient setting?
Vanessa, do you want to take that?
Yeah, sure. Thank you. That's a great question. So when we look at the data, the forms for outpatient and long-term care setting, it's very different because long-term care setting, you usually check for the 5 patient needs such as POTI, and POTI is actually the main culprit. And for outpatient, pretty much the post-fall huddle team players would be Sue, myself, engineering, police, and safety. So in the outpatient setting, you look at kind of like the architectural issues that the patient is facing, whereas in the long-term care, it's mostly anticipated physiological. So 2 different kind of settings, but at the same time, the huddle form that we have, you could check the check boxes, and at the same time, there's a section there where you could list down the unique reasons of the fall. And I don't know if Sue wants to add something else.
Yeah, I was just thinking that the majority of falls we did have at this campus were unfixable because they were, you know, thinkable episodes, medical issues that we couldn't fix. But then when we looked at the falls that weren't, we actually, the huddle depends on where the fall was. The inside ones was more EMS, Vanessa and myself. The outside ones was more engineering and the police and things like so. The fall would be a trip and fall because of it, but it altered the players where the fall itself was. So she and I would decide who should best kind of be on the huddle, and we'd hunt them down and they'd join us. They actually got great at responding to us. At first they thought we were nagging them and like, come on, I don't have time for this. But then when they saw that we were able to reduce all the falls, everyone kind of got more into it and more responsive. It took a while, but they kind of, you know, got on board with us, and they don't call us nags anymore.
Thank you. Ashley, did you have some other questions?
I did. I was just curious, are there any hospitals on the call that do assess patients in the outpatient setting? I know I believe the last group said they didn't assess, and I was just curious if any of hospitals that do assess, and if so, what that process looks like.
Not seeing any hands raised here.
Okay. And my next question, I guess it's related to the 5 Ps and hourly rounding. Some of the feedback that I've gotten from staff on the unit and a reason that they don't want to comply to the hourly rounding has to do with maybe scripting. And do you really encourage staff to assess every hour for those 5 Ps? And if so, is there certain scripting? Staff have voiced concern that, you know, going in every hour and asking the person if they have to go to the bathroom or if they're having pain can get annoying and redundant. So if there is something or scripting that you provide to the staff to make it less, I guess, annoying or more helpful.
So I can speak for, this is Amy, some of what we do on the Brockton campus. So we have it, our unit is broken down into 3 different pods. So instead of a nursing assistant going around and asking everybody about the 5 Ps, we probably have one nursing assistant maybe 9 to 11 patients on her pod. And we also have like stations in the pod. We have one of those roll-about computers in each pod, and they spend most of their time in the hallway, so that there's always visual contact with the residents here and the staff providing care. So that cuts down on the 5 Ps when we do our rounding, because we are always checking in. But cutting the pod into different responsibilities by different people seems to help, instead of having one person responsible for the entire unit.
Thank you. Do you feel like every hour someone is addressing those 5 Ps specifically? And have you had any negative feedback from patients that, you know, it's annoying or frustrating that they've checked on them every hour?
Well, we have a nurse with the nursing assistant on each pod, so I know in my case, if my nursing assistant is in a room or busy, then I take the responsibility. So there's either one of us, and we do communicate. We keep the clipboard in the hallway between us, so one of us will do it.
And is your process on paper or is it electronic for documenting?
We have it on paper. It's on a clipboard, and we write all the residents' names in the morning. And I make my initial round when I do my assessing of all my residents on my pod first thing in the morning, and we go from there.
And is that part of the permanent medical record?
I know that they do save them and keep track. Vanessa will have to talk to how long it's kept for, but we do turn it in at the end of our week.
So just to add to what Amy said, and it's a great question, it's not part of the medical record, but if a patient falls and we have a litigation or a lawsuit, on our documentation system, we have hourly rounding as a checkbox, so that's documented by itself. But the checklist that Amy uses for long-term care, it's not kept. It serves as a guide. Thank you.
And hi, this is Julia. You know, another aspect to consider is, you know, if you're feeling like it might be too much, you know, some patients are getting annoyed or those kinds of things, is really looking at individualizing the frequency and intensity of the rounding for each patient. Now, it's a little more complicated because you're going to have to, like, some will get it more frequently. You know, maybe there's a patient who needs it more frequently than an hour, and then maybe there are some who don't even need it every hour. You know, so it might really vary. You know, certainly if everybody gets it every hour, that might be easier for people to remember. But, you know, as always, you know, the ability and the idea of individualizing their plan of care, that might be something that would help in your situation where it sounds like people are feeling like for some patients it might be a little too much. And then you can, you know, determine the best use of your nursing resources on if there are some patients who don't quite need it every hour.
We also have a communication board in our hallway where PT writes the times and OT and KT write the times that they come up and that they're going to be taking residents off the floor. So on our clipboard, I'll write those times so that we have the communication between myself and the nursing assistant, just so we know at those times, you know, to make sure the resident is either ready for therapy or at therapy.
Okay, thank you very much.
Okay, great. Are there other questions that anybody would like to ask at this point in time? I know we moved through some of the material fast, so if there were some other things that you would like to have gone over again, let us know.
Michelle?
Yes.
Sorry, this is Betsy at Stratus Health. I wanted to ask a question of Kristine from the first part of our presentation, if we have time.
Yes, please.
Okay. Thanks to everybody for your presentations today. Very helpful. Kristine, I want to just acknowledge the frustration that your team has experienced as you've tried to incorporate the hourly rounding and our intentional rounding and some of the challenges that you've encountered. You mentioned that your unit and your team are still experiencing falls, and that when you looked at that, you were finding that the standard of care that you were aiming for, whether it be around the rounding or otherwise, wasn't, when you examined those falls, you were finding that wasn't happening. Knowing that you've got a very, a unit where folks are coming in and out frequently, could you speak to what were some of the findings you had around what led to folks not being able to follow the standard that you had set up? What kind of things were they encountering?
This is Rose. Kristine had to leave the meeting, so I don't know if I'm going to be able to answer that. It's a great question, though. I guess I might have to, I'm not sure how to handle that, get back to the group, or?
Sure. That'd be fine. I think that's one of the challenges that probably any hospital can appreciate, that when you set something in place and you're hoping that folks will follow it, we want to get down to finding out what got in the way of staff from doing the things that we thought was part of the process that we thought was feasible, just so we can understand it. So thanks a lot, Rose.
Right, right. Are there other questions that anyone has? We have 2 minutes left.
This is Rose. I just had a question about preventable. When it is determined that falls are preventable, how is that brought forward to the staff and to the organization as a whole?
Hi, this is Julia. I don't know if I can take a first, crack at that, and then if Vanessa wants to add. But, what I find most helpful about determining falls being preventable or not preventable is then, to look at what the reasons might be and if there are any trends within that. So as I was sharing the example of one team, for example, finding the highest percentage of their preventable falls were anticipated physiological falls related to toileting. So then the team as a whole can focus on, if we really want to have the greatest impact on our preventable falls, let's focus on what we can do to make toileting safer for patients. So that's a way to do that. I think as far as the individual, the team itself looking at, or the people on the floor looking at that, one of the things I like to think about is it's a tough one, because if we say it's preventable, then does that mean if it was my patient and I'm the nurse caring for them that I did something wrong? I don't want people to feel guilt or feel badly, because that doesn't help anything. One of the things I like to bring up is there anything that the falls team can do to help you to prevent future falls, or to ask them what they think might help in the future. So I don't know if that's what you're getting at, that delicate balance between looking at root causes but not wanting people to feel blamed.
Yeah, exactly.
I don't know if Vanessa and your team have any ideas on that.
Julia, you answered it all perfectly, so I don't think I could add anything else.
Okay.
Are there any other questions? I know we're out of time. I did have one question that maybe I could pose and then follow up with Vanessa and Julia to share with us, and that is really about, how frequently should you be measuring the process measures around fall, and how, and sharing that data back with the hospitals, so that, they're aware of what's going on and whether or not your activities have been actually helping.
So, Julia, you want me to answer that one, or?
Sure. Go ahead, Vanessa.
So, good question. So, in terms, so speaking as a falls prevention nurse, when something happens on the floor, we get the incident report. If it's a major injury, moderate injury, my first stop or first call is the floor itself. They already did the huddle. The nurse managers are great at sharing the information with the staff. How can we improve our processes in terms of falls prevention? As a patient safety manager, we do quarterly report of all falls in all 3 medical centers. When we presented to the medical center director, for example, in outpatient clinic, at first they didn't want to grant funding for the construction, but once engineering and administration saw that the fall rates are high because of this uneven walkway, and the rates of the major injuries, they decided that, what, we will get funding, and at the same time, we've improved our processes from an engineering perspective. So it's really it really depends in the front line where the fall happens. We tend to give them the feedback and the recommendation like within at least a day from patient safety. But the nurses do the post-fall huddle within the same day or at least like an hour or so, as Julie has mentioned in the past. But from an administration perspective, if you really want facility-wide changes, we do it quarterly, and even every year we have a falls aggregate review, so we review all falls, and the results are presented to administration. And whatever the recommendations are, usually administration would approve it because they see the numbers. And I hope I answered your question.
Yeah, and I was also kind of more interested in the process measures that, you know, related to the fall huddle. You know, how often it's being done, and actually looking at your slide, Julia, I think it's slide 26, just trying to, you know, I guess some helpful tips related to measurement for the falls I think would be helpful. We're not just the fall metrics, outcome measures, but the actual process measures.
Right, exactly. You know, I think of it like this. If I want to be able to run faster, you know, how many times a week am I going to the gym? You know, well, the gym's not working, but I'm not going, you know, that kind of thing. So I have to look at my process. And as far as the frequency, I agree with Vanessa. I think it really depends. And, you know, if we do it sooner rather than later, then we have a chance to find out why it might not be working, kind of related to the question that came up earlier, why aren't people doing the intentional rounding, to have like an open discussion with people about what's working and what isn't about the process. You know, waiting too long to find out, well, all this month I haven't done what I, you know, set out to do in terms of my process. You know, I'm a big proponent of, you know, short cycles of change sooner rather than later, so you can find out if there are any problems and address them at that point.
Okay, great. All right, well, are there any other questions? I know we've run over, so I'm going to go ahead and, if there are no other questions, I think we'll go ahead and adjourn. Let me just note that on the very last slide, and you should all have a copy of those slides, our next webinar is in November. On the, let's see, the 18th. So we hope you'll all be there. And if you wouldn't mind, please take the webinar evaluation survey. Again, we want to know about your availability in December. All right. Well, thank you, everybody, for joining us today.
Thank you.
Thank you. Thanks.
Bye.